Who's in charge of the mics?
Anybody? It's working now.
Nice. Good morning, everyone. Welcome to our breakout. Sorry we're starting a few minutes late. We do have to finish at 11, so I do want to get started. My name's Stu Gitlow. I'm the moderator of the session, and I'm the past president of American Society of Addiction Medicine. I know some of you have seen me and several of our panelists before. What we have today is a panel discussing the current state of recovery in America. Let me talk a little bit about that before we move into the panel discussion. I got an email this morning from an old college friend whose oldest daughter, had just died of an overdose. And my first thought was, as I'm sure your first thought is, another person with addictive disease has died of an overdose. And then I started to think about it. We talked a little bit. And this was a fellow that I went through college with. He used marijuana on a regular basis during college and didn't have any difficulties with it. Grades were good. He graduated on time, had a perfectly good career, continuing to use marijuana on a regular basis. And he gave those values to his children, who also, as they got older, used marijuana on a regular basis. His daughter went off to school, did very well, had a brilliant engineering career that had just started, and in her obtaining marijuana just for social use, not having had any difficulties with it in the past, the marijuana that she got turned out to be laced with some fentanyl, and she overdoses and dies. And you sit there and say, well, it wasn't somebody with addictive disease. It was somebody who had made a lifestyle choice. And now you sit here and you say to yourself, well, how many of these people that have overdosed over the past many years have addictive disease, and how many don't? And how do we figure out what the risk is and how it differs between those who have addictive disease and get into trouble as a result and those who don't? And it starts to beg the question of what recovery is. Do we use the term recovery only with individuals who have been identified as having addictive disease, or do we also use it with individuals who use on a social basis and then stop for whatever reason? Are both groups in recovery, or is there a difference between them? And how do we think about this, and how do we reflect in our heads as to what addictive disease is, if not simply use of an addictive substance repetitively? Well, then you get into that last little bit of the definition. The usual definition is use of the addictive substance repetitively, but also not in one's best interest. In other words, you've already gotten drunk and fallen down the stairs. You know that's likely to happen again. Do you keep drinking anyway? You've already been arrested. You know that's likely to happen if you keep doing what you're doing. Do you keep doing it anyway? But what happens if nothing bad has happened? If you're going on with your life and not having any downside? Well, I guess it depends. Is the drug toxic? Is it causing some future harm or potential for future harm? Shouldn't that count? Right? We count it for people who smoke cigarettes. They have addiction, even though they're not likely to go to jail, and they're not likely to be arrested, and they're not likely to immediately drop dead. But they will have a long-term problem as a result. We call that addiction. Shouldn't we call it addiction if they're just drinking or using marijuana on a regular basis and not having any immediate harm as a result? Or does that interfere too much with what the diagnosis is? So as we're talking about recovery this morning, think to yourself, what do we mean by recovery? exactly how do we define that term? And I'm not going to do it here. And I'm going to let our panelists broach that topic. But it's something I'll hit upon in my talk later on today, is this question of how do we talk about recovery for our own community, let alone the general public that already doesn't understand addictive disease. All right, our panel today. We're going to start out with Michael Langer, Deputy Director of the Division of Behavioral Health and Recovery, Washington State Healthcare Authority. And I'll introduce each of our other panelists as we go. And where is Michael? Did he leave?
He's probably stepped out because he sees
All right. I can't start with the person I was told that I have to start with if he's not here. All right. I'll tell you what. We're going to move. Dr. Langer, are you here somewhere? No. Dr. Clark, would you like to be first?
Dr. Clark is going to go.
All right. Dr. Wesley Clark, faculty at University of Santa Clara in California, former director of CSAT, you've seen him many times before, and a former board member at the American Society of Addiction Medicine. Welcome, Dr. Clark.
Yeah, I saw Michael hustle out of here, so he probably got summoned, given that he was an official of the state of Washington, operating under the auspices of the governor and that sort of thing. That sort of thing happens. You get summoned. People get summoned. So the topic is the current state of recovery. And, people should move forward a little. You're clustering, so you can't blame COVID for the reason that you're so far removed, because people are still in little clusters. If there was only just like one person every third seat, I could understand why people were. But so come forward, because part of the breakout is actually involving you. As Stuart was saying, Stuart Gitlow was saying, we have to think about what recovery is, and we have to give some thought to what it means for you personally, as what it means for your house, what it means for your community, because you all are experts, and being an expert means that people will ask you questions, just as Dr. Gitlow's friend was relating the tragedy in his life with regard to his daughter. And that then becomes an important theme. People will rely on your life experience to ask you questions. And in the situation that he describes, the harm reduction people would say the young woman died not because of the use of marijuana, but because the drug dealers contaminated the marijuana with fentanyl, and she was unaware, so there should have been some other strategy. The harm reduction people would say that you could continue to use if you didn't have to rely on, shall we say, unscrupulous purveyors of substances that make you high. But people who develop issues with substance use are generally not in that category. If you look at this slide, you'll hear a lot about opioids, but what others are pointing out recently is that we're in the fourth wave of despair stimulants. And this is where the fentanyl and the stimulants, and people are using fentanyl like sugar or salt, sprinkle a little fentanyl on this and sprinkle a little fentanyl on that. And as a result, people are dying, and people are surprised. So we have in the recovery environment this whole notion of what it is that you're using and how that use affects you. But I'd like to start off with the importance of Oxford House, as we said in doing Paul's memorial. We have to start off thinking about you and your relationship with your own autonomy, your own decision-making. I like to point out that in the substance abuse treatment system, apart from Oxford House, the OIG, the Office of the Inspector General, views the professional or driven substance abuse treatment system with suspicion. It says, as you can see on this slide, the OIG and its law enforcement partners have a substantial enforcement experience that demonstrates the pervasiveness of fraud in treatment programs that serve neither the best interests of patients nor taxpayers. So the beauty of Oxford House, as was pointed out, as Paul envisioned and as Yvette was so eloquently describing, is you are making decisions about your lives collectively. You know what you're doing. You know whether someone's attempting to use or using, or someone's attempting to relapse or reuse. You are in a position. You can't simply rely on the professional delivery system. The Office of the Inspector General and the Department of Justice, they say, hey, even in the professional delivery system, there are people who are sly, slick, and jive. So recovery has to be a highly personal thing. And it can't be a sleight of hand. It's got to be a highly personal thing. What the legal system is saying is that there's waste, fraud, and abuse. And I use contingency management as an example of some of the concern. Now, in contingency management, people are given incentives, either gifts or vouchers, to remain free of substances of use. But what the government is concerned about and the legal system is concerned about is false claims by the delivery system, kickbacks, monetary inducements, self-referrals, waste, fraud, and abuse. And that's what's keeping the contingency management from being used. The professional delivery system is viewed with suspicions on the part of the regulatory authorities. Again, the beauty of Oxford House is that you're not subject to that kind of scrutiny. You are subject to the scrutiny of each other. And that is a very positive thing. There is a concept in the law called the False Claims Act. And the relevance to recovery is that indeed the providers, professional providers, sometimes engage in illegal behavior. They make payments to Medicare or Medicaid. They get money from Medicaid or Medicare, and they make payments. They get payments they know that are false. And there are civil and criminal penalties associated to the False Claims Act. But what is also peculiar about the False Claims Act, it relies on people who essentially participate in the fraud, reporting the fraud. So if it's a legal concept called qui tam. So if I'm a clinician in the fraudulent behavior and I decide I get fired or I get upset, I can report you to the Justice Department and I can sue you on the part of the government, and then I get money. So even the government then engages in this kind of paradoxical behavior. It's contradictory. But what we're dealing with is the issue of if we rely only on the professional delivery system, it's a mistake. So recovery also means recognizing that processes and procedures can't be external. That's the beauty of Oxford House. It's internal, you're doing it. Now, I like to see. There was a case from last year where a mental health and addiction treatment service provider violated the False Claims Act and the Controlled Substances Act. The Controlled Substances Act is the act that governs things like marijuana, fentanyl, any of these psychoactive substances. And it says you can not use it, or if you use it, it has to be under certain circumstances. In this particular case, the professional treatment provider billed Medicare and Medicaid allegedly for services performed by unqualified practitioners. So when you go into a professional clinic, a professionally driven clinic, you are relying on the fact that the people who provide you services know what they're doing. So you see, the beauty of recovery is you know that the person who is in your house knows what they're doing. They've been there, done that. And they're demonstrating personal responsibility. They're demonstrating a commitment to recovery. But in this case, they billed, the clinic billed for services that, using billing codes, they failed to document the use of controlled substances, and the government relied on a whistleblower, or the key tam action, filed by 2 former employees. So the whistleblower was able to deal with this and get money. And the clinic settled for over $15 million. But it suggests that the responsibility for recovery, as Oxford House articulates, belongs with you. And it's an important thing. It is available, as Yvette and others have pointed out, as Kathleen pointed out, and people with long-term recovery point out, you can do it. Recovery also is confronted by the issue of stigma. And I want to point out this whole thing about disability benefits. Disability issues surface in housing, the Fair Housing Act. And you heard that stated earlier from the attorney who is in recovery. But it turns out that there was a time when you could get disability payments for drug use and for alcohol use disorders, drug use disorders and alcohol use disorders. But people started examining that, and this is where the issue of stigma comes in. If you got diabetes and you continue to eat poorly, eat a lot of sugar, don't watch your weight, don't do exercise. If you've got hypertension, don't exercise, don't watch your weight, don't watch what and you can get disability payments if you're disabled as a result of these conditions. But if you have an alcohol or drug problem and are trying to recover from it, you can't get disability payments, in part because the Congress in 1996 decided that if you had an active substance use disorder, or actually if you had an alcohol or drug use disorder or a substance use disorder, you could not get SSI or you couldn't get disability insurance at all. So the other thing about recovery is acknowledging that you also encounter stigma and discrimination officially. And so these are things that we have to keep in mind in terms of the current state of the law and of attitudes. It continues. Some will speak of the fact that people say, I don't want to live next to people who are actively using. And this is what Paul would often point out. Let's see, you have no problem living next to somebody who's actively using, but somebody who is in an Oxford House not using, because what's the requirement in Oxford House about use? That's a requirement. So the people who are not using are deemed to be suspect, while the people next door who are running over your mailboxes and actively using are welcome. Excuse me? Am I missing something here? But this is where the stigma and discrimination issue surfaces, so in official policy and community attitudes. So this is the 32nd Recovery Month activity. This is September's Recovery Month. So Oxford House is celebrating its achievements and its achievement during Recovery Month. So it's fitting and proper that we talk about this. It's fitting and proper. So recovery is gained through peers helping peers in a democratically run, safe environment, and that has to be applauded because that's above reproach. Oxford House has to deal with a full range of issues, but the most important thing is you're dealing with each other. And Yvette reminded me that we are all family. And even though I'm not in recovery, I think I'm a part of the family because you're a part of my community. And I think family extends to everyone who embraces your efforts to live a clean and sober life and to return to contributing to society as Oxford House. So I would like to ask your permission to use the phrase or the word family welcome family to this discussion. Recovery is achieved by you for your communication. It has to be a clear message to yourselves, your family, your community, the nation, that recovery is not only possible, but it can be engineered by every people who's experienced a substance use disorder. Very people. You can facilitate recovery. And when I was at CSAT, that was one of the major issues. I worked with a staff person named Kathy Nugent. And we started to focus using recovery-oriented systems of care on making sure that peers played a critical role in decision-making, providing their lived experience as a way of sustaining the efforts of the professionally driven delivery system. So that became an important part. It's not just the doctor, the nurse, the professional counselor, all of those help. Those people help, and it's not a criticism of professionally delivered delivery system. It is that you can't rely on that system to address your needs. SAMHSA in 2010 came out with a definition. Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Does that sound familiar? Is that not what you do in Oxford House? And that's what we want. We want you, we want everybody, not just someone who's recovering from alcohol and drugs, but anybody who's alive. So what you want is no different from what anybody else wants or should want. I suppose there are those who may not want, but in addition to SAMHSA coming up with the definition, but I think Oxford House has been pointed out over and over again, 1975 and even 12-step programs, always relied on you addressing your issues, we all address these issues. The NIAAA just this year has also came out with a definition. Recovery is a process through which an individual pursues both remission from alcohol use disorder and cessation from heavy drinking. Recovery can also be considered an outcome such that an individual may be considered recovered if both remission from alcohol use disorder and cessation from heavy drinking are achieved and maintained over time. For those experiencing alcohol-related functional impairment and other adverse consequences, recovery is often marked by the fulfillment of basic needs, enhancement in social support and spirituality, and improvements in physical and mental health, quality of life, and other dimensions of well-being. And continued improvement in those domains may in turn promote sustained recovery. Again, look at your own philosophy. Look at the philosophy. This is what we want. It has nothing to do with substance use per se, because this is what most people want. I always ask people, how many of you want to be happy in your lives? Okay? How many of you prefer to be miserable? No, there's always one person who likes to be miserable. Exactly. But the point is that what recovery is that people want good lives. And so these official definitions only echo what you're already getting from Oxford House, the 12-step programs. The objective is the restoration of your ability to function in society in a way that make you feel happy, fulfilled, and that you can contribute. In addition, since we're talking about the current state of recovery, you'll hear from ONDCP this afternoon. You're going to get a video from Dr. Gupta, who's the director of ONDCP. They have embraced recovery. In their National Drug Control Strategy, there's a whole chapter on building recovery, or a recovery-ready nation. And so they go through a lot of descriptions of issues of recovery. But it's also interesting in that they reference Oxford House. So you're sitting on a gold mine, and the question is, are you prepared to mine for gold? And it's your life that other people kind of envy. Oxford House represents a non-clinical, Oxford House represents a non-clinical pathway to recovery with peers and community facilitate. John Kelly argues that there are things like recovery residences, recovery community centers, peer-based recovery support, education-based recovery services, employment-based recovery services, faith-based recovery support. So there are all these permutations in the objective in recovery. And in addition, recovery is in. Although the effort to pass a 10% of the block grant set aside for recovery failed in FY 2022, there were 498 organizations, including 30 national organizations, that favored setting aside 10% of the money that's in the block grant, which is over $1 billion, to devote to recovery. So these are some of the organizations that joined in this call for funding for recovery. And the reason this is important for Oxford House is there used to be a loan program that allowed people to borrow money to buy a house, to start a mortgage, and to pay it back. And it kind of fell into disfavor at the state level because people were looking at these professionally driven models. And they made it optional, and then Oxford House was unable to get the loan money. Now, those of you who live in states like Washington or California, you know how much housing costs. So even starting a house, you got to get the house, and property is expensive. And you know, California, I just left California. In California, the average cost of a house is $700,000 in some parts of California. So you think about that. So, which means that it's difficult to start a house. So we need to make sure that the beauty of Oxford House is you would be able to pay your mortgage collectively, so that you're not depending on a handout. But the issue is, in order to acquire property, you need to have at least the down payment to begin the monthly payments on the mortgage. So this was done in FY 2022. In FY 2023, the United States House of Representatives has passed a bill, and they are reestablishing this 10% set aside. Now, this hasn't been passed into law yet because, as Yvette pointed out, others will remind you that the state of affairs in the political environment is, shall we say, not very stable. But in any event, so if there's this 10%, every state will have to set aside, they'll get a block grant, and then they'll have to set aside 10% of that block grant under this proposed law to develop local recovery community support institutions, including but not limited to recovery community centers, recovery homes, and recovery schools, or programs to mobilize resources within and outside of the recovery community to increase the prevalence and quality of long-term recovery for substance use disorder, and to provide peer-based recovery coaching, individual and group supports to individuals and families led by those with lived experience with substance use disorders and delivered in person or using technology. Now, there's going to be a breakout section on technology in Oxford House tomorrow. I think it's tomorrow. It's in your agenda. But the key issue is the House language captures this spectrum of current concepts of recovery support institutions like recovery community centers, recovery homes, recovery schools, programs to mobilize resources within and outside of the recovery community and to increase the prevalence and quality of long-term recovery. And the beauty of Oxford House is that its commitment to this is long-term. It's already done. I mean, when I'm reviewing what Oxford House embraces, housing for individuals, housing for men, housing for women, housing for women with children, housing for men with children, housing for people who are LGBT, housing for American Indians, Alaska Natives, housing for Hispanics, housing for African Americans, housing for poor whites, housing for Appalachian whites, housing, but it isn't just housing. As Kathleen points out in her summary in the brochure, Oxford House is not just about housing. There are those who embrace the concept of housing first. All you need is a house and your problems will go away. And indeed, for many homeless people, housing first seems to work. But if you're talking about recovery, does that satisfy what else is going on in your life? Only you can tell me. Does it satisfy what else is going on in your life? By the time you see yourself as needing help, many people have had issues with a host of things, jobs, family issues. When as a clinician, I was fond to say, your family is the last to let you go and the last to take you back. Why are they the last to take you back? Anybody? You burned the bridges. They've heard it before. I'm not going to do this. Uh-huh. And that's the point. They will take you back, but they're looking for something a little more substantial than your word because they've heard the word before. They've heard the word before. So I always felt that what we should be doing is making sure that we have things like Oxford houses where the full person could be addressed and that recovery could be facilitated by dealing in a comprehensive way, not just with a warm bed and some food, which are important. I don't want to minimize it. Not even just with a job, but what's going on inside your head, what's going on inside your character, what's going on inside with you. The House is not, this particular Appropriations Committee is not the only entity that's dealing with the issue. They want to provide resources for community-based services necessary to sustain recovery, including access to transportation, job training, and educational services. So these bills, should they pass, will assist you in your recovery because indeed you have to deal with these other issues like transportation. They want to provide activities to reduce recovery-related stigma and discrimination at the local level. We don't want people saying, oh, you're an addict or alcoholic, or using the more contemporary language, you're a person who's experiencing substance use disorder. Paul used to call it alkies and druggies, or drunks and druggies, but that language is no longer acceptable. We say that language is important. But for Paul, it wasn't the language, it's what were you actually doing? Are we using labels and the focus on labels as a way of avoiding dealing with the struggle that a person has to go through? And I'll leave that for you to decide. I've adopted the newer language, but the key issue for me is how do we make sure that you have access to all of the services in the community so that you can enhance your life. They will provide technical assistance to organizations, et cetera. They're going to prioritize programs for underserved populations. They're going to promote, he's back. All right, so, and then they'll make funds to help the recovery set aside to support the operating costs for organizations that provide these services. I'd like to point out in the Appropriations Committee, because I'm running out of time, that for FY 2023, the Appropriations Committee is proposing a lot of money for recovery-related activities. Recovery community services programs, building communities of recovery, peer support technical assistance, treatment recovery and workforce, youth prevention and recovery initiatives, and a comprehensive opioid recovery centers. The Senate is agreeing with the House. They, in terms of the block grant set aside, they proposed that 10% set aside. So if the federal government, the Congress can get its act together before the election or immediately after the election and pass an appropriations bill, there will be a 10% set aside. And if that happens, then we want to make sure that Oxford House is aware of that, so they can approach people like Mr. Langford over there and say, okay, we need money to set up a house. Although Washington has done a brilliant job of setting up houses, so I'm just needling him because he's in the position. Washington has done a brilliant job, and I want to say that I admire and respect what they're doing because their commitment is demonstrated in the reality that you've heard this morning. In addition to the Congress dealing with this in terms of current issues, there are a lot of recovery-oriented organizations. In addition to Oxford Houses, there are Faces and Voices of Recovery, which devotes itself to advocacy and advancement. There is a newer organization called CARD, the Center for African American Recovery Development. There's another organization like Young People in Recovery, and there are advocacy groups. But at the end of the day, all of these things don't matter if people cannot enter recovery and if people who need the recovery, I'm being given the hook, but I just want to make sure that you know it's not about the professionals and it's not about the organizations, it's about you. And I'm glad that you're all here, and I think Paul and Jane and Kathleen and all the other people who rally around your recovery are glad that you're here. Thank you.
So one more thought question while we're on the topic of recovery. I saw a pilot about 10 years ago. Pilot was American Airlines international captain. He had ended up in a bar brawl after many years of over-drinking, never involved in a flight incident, but he was on a layover in London and got into a bar brawl, ended up in jail, and couldn't make his flight the next morning back to New York. He ended up in what's called the HIMSS program at the FAA. The FAA pulls the pilot's medical, and they have to go through a 28-day rehab and then be seen regularly by an addiction psychiatrist and be subject to regular drug testing and participate in 12-step for an extended period of time. And they were followed that way over a 5-year period. This pilot went through the process, and after 6 months of demonstrated abstinence, he was able to get what the FAA calls a special issuance medical certificate, where he's closely followed but able to return to the cockpit and fly. And he did very nicely. He went to the program, he went to 12-step, he had a sponsor, he worked the program, he was tested regularly, had no evidence of any substance use, and he year and year and year, and finally he's done that for 5 years. At the end of 5 years, the FAA said, "You have done very well, you're released, you have a normal issuance medical certificate, you no longer need to be followed as closely as you have been over the past 5 years." Where did this pilot spend the next weekend? In jail. So the question is, during those past 5 years, was he in recovery? And when I talked to him again after he once again reapplied for the special issuance, I said, "What happened?" He said, "Well, I was doing everything I was told." And I said, "And?" He said, "Well, I was doing everything I was told. I was checking the boxes, exactly what the FAA told me to do." I said, "Did you think you needed it?" "No. But I did it." And so as I'm reading the various definitions of recovery that were displayed, it becomes very difficult, because you all answered the question correctly. Was he in recovery? Clearly not. But he didn't have any of the symptoms that we use to define addictive disease during those 5 years. Makes it very difficult for researching the subject of recovery. How do we research it if our very definitions of addictive disease don't have the terminology necessary to accurately define whether or not somebody is truly in recovery? Anyway, not something I'm about to answer, but just something I'm about to ask. Next up, we have Michael Langer, Deputy Director of the Division of Behavioral Health and Recovery here in Washington at the State Healthcare Authority.
Thank you. And for those of you that were here a little bit early as this panel started, you saw me leave the dais. I'm kind of a rule follower. So I looked down and I saw the program and it said state agency relationships. And I figured I'm a state agency and you want to know about relationships, but that's 3 floors down. So I thought I was in the wrong spot, and I was very nicely walked down there and then realized, no, you're not in the wrong spot. You're supposed to get back up there. So I'm back. I'll keep it short. To just follow up on Dr. Clark's comments here a little bit and what's being proposed back in the other Washington, as we like to call it, the 10% on the block grant. I am very proud to say that we're at 20% in Washington State, or over 20%. So when we went and looked at that and said, what else we need to do? We were already doubling it, and I dare to think that we probably will continue to grow that. It was pretty, I started in the state quite a few years ago, and it was treatment. It was treatment, and then there was a couple of us that did that prevention thing over here. Times have changed a lot. We have a full-fledged prevention section. We have a full-fledged adolescent section, full-fledged adult section, all for treatment. And then we have a whole section just on recovery support services right now, and that just continues to grow. Really, really important. And I think you'll find that in other states. We're starting to look at, even on the national association level, the treatment people get together, prevention people get together, but it was just a few years ago that we started to identify in the states, well, who's leading recovery? Because they need to work across lines as well, and so some of that work is happening. Matter of fact, Mo Bailey's here. Mo, I don't know if you're in the audience or not. She is here. I forgot to mention her earlier. I was going to say, if she's not here, you need to all tell her I mentioned her name. She's embarrassed now. She helps lead all of our peer work and a lot of our recovery work, so thank you, Mo, for your leadership. I'm going to take just a very, very short amount of time because what I've been asked to do is kind of explain a little bit about the state work and what we invest in. And I think most of you know this, but I will give it to you anyway. And then a few challenges that we still face, and then I'll get off here real quickly. So in our state, we have about 250, 300,000 people this year that are in need of recovery, that we've identified them as in need of treatment, but folks know you get to recovery a variety of ways. So I like to say in need is to begin their journey for recovery. Last year we served about 80,000 people in the state. So that gives you a sense of there's a gap there, right? Not everyone's getting what we feel they probably would benefit from. And of course we know not everybody's ready, but that gives you a little sense of our state. One of the more sobering statistics I'll throw out real quickly, and you're facing it where you're coming from as well, is we've lost almost 2,300 people last year to the overdose epidemic, really. Most of that's opiates, most of that's fentanyl. You've heard of that already today. You guys know that from those that you're living with or that you're working with. Really tragic and something we need to collectively work together on. So what do we do at the state? What's the suit and the bureaucrats do back at in Olympia or in your state capitals? Each state's different. If you don't know your state director, alcohol and drug abuse director, or the state agency that administers these funds that Dr. Clark and others have talked about, get to know them. That's one way of supporting the work that you're doing. And most of you probably already have that relationship. But for our state, we have a place to call. There's a couple lines to call, recovery lines, if you're in need of help. The new one nationally, 988. Please be aware of that if folks are in crisis. But we also have a recovery line, a warm line that people can call and get help. And I see some heads nodding, so hopefully you're taking advantage of that. Get my notes here real quickly. So what do we offer? I'll do this in a 2-minute drill here. Withdrawal management, detox, right? That's something that the state pays for. Depending on who you talk to, we need a lot more, but that is available in our state and in many states. Outpatient treatment, right? Residential treatment is available here. We have it specified, so we have adolescent programs. We have programs for pregnant and parenting women. We have some hospital-based programs if that's the level necessary. And so we do invest in treatment, and for many of you, you're well aware of that and how that operates in your state. We also support medications for opiate use disorder, but also for other addictions. And this has been a growing area during the whole crisis around opiates. We've had to bring everything in the tool chest together in terms of how to help address this. So we have a lot of prescribers in our state now for Suboxone, and we certainly have grown the number of methadone clinics, or OTPs. I'm trying to organize that more so it's more one stop. We also have a couple vans now or actually more than a couple vans that the legislature has invested in to move about and go to where people are to help out with the medications. We also have set up hub and spokes so that we have our traditional treatment programs and our prescribers referring to one another. So depending on what door you go in, you can get support across. Dr. Clark talked about contingency management when I decided to walk back in the room. Yeah, contingency management up there, and he and I have spoken a little bit about that. We do support it in our state. We're using some federal dollars where we're allowed to do that, really incentivizing that whole treatment process and find ways of engaging folks. So we hope to do more of that, and we continue to invest in drug courts here in the state of Washington as well. Current, I heard oh yeah on that. It's probably some drug court graduates here. That's wonderful if that was your journey. In the recovery engagement and support services, let me look at my clock here real quickly. We have a new program in our state called Recovery Navigators. Every county has individuals now, many of them are peers, that are out there engaging folks on the streets, getting referrals from law enforcement, not into jails, but referral from law enforcement for possession type charges, or possession and other kinds of things. And their point is to meet people where they are, to try to start to walk that path of journey of recovery with them. And so we're delighted by that. That was sort of sprung out of our Blake decision in our state, which decriminalized possession of any drug for a couple months until they rectified some of that during the legislative process. But nevertheless, we have more people out there touching lives, and I think that's what we all want, and we're thrilled to see that grow. Certainly embrace the idea of addiction being a health issue, not a criminal justice issue, and that's something that you're seeing more and more in our state talked about. We have peers out in homeless camps, hospital emergency departments. We have a number of recovery residents led by, as we've been talking about, Oxford Homes. And by the way, wouldn't it be wonderful, and my Washington folks, you can close your ears now, but if every state not only caught up to Washington, but surpassed us, right? Like, let's do more homes everywhere, and we'll keep adding on to ours, but you guys please keep adding on to yours as well. We also have what we call foundational community support. This is a bureaucratic term around helping people with employment and housing. And we're getting not only SAMHSA, but CMS and other folks to pay for that. So we feel really good about that. This is what I'm going to leave you with, and these are some challenges we're facing not only in our state, but across the country. It's difficult to expand services without the workforce. We really need more people working in this field. Thank you for outreach workers. Double up on outreach workers. And those of you that are so inclined and you're in the homes now and you believe this is a calling, we could use you in the outreach and treatment and recovery beyond Oxford Homes as well. We need more people working to support each other. The state, well, I'll stop with that. Enough of the state. Let's go on to a topic we talked about a little bit, the opioid overdose crisis. I will just say, please, 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 if you don't already, have naloxone in the homes. Have a bunch of it. We put it up on each floor in our building, right? Bureaucratic building in Olympia like 2 months ago. Just got a note this morning. Somebody overdosed in the parking garage, and they were able to get revived with naloxone. Please have it in your homes. If not for your residents, the people on the sidewalks outside your residence, everywhere you're going to go. We need help getting that out there. And then accept the medications. I know many of our homes do. Please, please accept people who need that support as well as part of their journey. Stigma, we need to continue. We talk about stigma in terms of celebrating recovery. Thank you for doing that. Also, there's some stigma around Oxford Homes I don't quite get. In my experience, the Oxford Homes don't drop people. If someone does be asked to leave for a period of time, I have seen them supported getting into treatment, welcomed back. Just a whole lot of love and encouragement. So please keep that up. I know stories get kind of out of hand sometimes, but please work on the stigma for recovery, but also stigma for Oxford, and let's make sure people understand that all folks are cared about. Housing, we'll keep we do need more housing, and we need more recovery housing in general. Be inclusive. We need to make sure that all sectors of our population feel welcome, including in Oxford Homes. I think you're working on that. Here's one that may not, here's one, and I'm talking from the Healthcare Authority, but also I really believe this, is we need to do more around the tobacco issue as part of recovery. Folks, everybody's working too hard to leave this planet early because of tobacco. We need to do need your help to work with each other and see how you can encourage each other to address the tobacco addiction. We need your ideas about low barrier access to treatment. If there's ways we can cut down on barriers to accessing the treatment when it's needed, please let us know what that can be. And I'm going to stop with that because I know we're really crunched on time. And thank you so much.
All right, Dr. Olson, welcome. We now have Ingrid Olson, the Assistant Secretary for Mental Health and Substance Use at SAMHSA. And I'll keep my introduction as short as that, but Dr. Olson, I go way, way back. I'm proud to see you here. Thank you.
Great, thank you so much. And I hope everyone can hear me. And Dr. Gitlow just elevated my position to the Assistant Secretary, but I am actually the Director for the Center for Substance Abuse Treatment. And after listening to Dr. Clark and Mr. Langer, you would have thought that Dr. Clark at some point would have been the CSAT director. So I love just being able to follow both of them. And I do bring greetings from Dr. Miriam Delphine Rittmann, the Assistant Secretary for Mental Health and Substance Use, as well as Tom Coderre, the acting Deputy Assistant Secretary. Unfortunately, neither one of them are able to be here today. And I am also so sorry that I can't be there in person. It just sounds like an amazing, amazing conference and just such an incredible energy in the crowd as well. So I also will be short, but I did have some slides to share with you all that I just wanted to use to center my remarks. Except I can't share it because it looks like I've been disabled from participant screen sharing. So I will just, I will kind of speak then through my remarks. I also just wanted to highlight that give a big shout out to Lois Gilmore, who is the Assistant Regional Administrator for SAMHSA, who is present at the conference today. David Dickinson, the regional administrator, also is out of town, so he was unable to be here. But I wanted to just, and I have to say, following Dr. Clark, following Michael Langer, you've heard so much already about not only the state of recovery in Washington State, but also just about all the various different things that are on the horizon to some extent here in Washington, D.C. And I just also wanted to highlight that, we're talking about all the tens of thousands, hundreds of thousands of people who have lost their lives. And this morning, the federal government has actually allowed me to continue to see some of the the patients that I have had the opportunity to be part of their recovery journeys for the past decade. And I learned this morning that one of our very long time patients, she died this morning, not from her substance use disorders, but from her obstructive pulmonary disease, so COPD. So I think the shout out to tobacco and really looking at tobacco is incredibly right on. I also just want to say that the stigma that people who have a substance use disorder, people who are in recovery face is something that has long been driving my work in this area for the past 20 plus years. And I always wear, and I don't know if you can see this, but this is a band that was given to me by the mother of someone who, or the mother of, she had a son who overdosed and died. She had a brother who overdosed and died, and she had an uncle who also had lost his life to addiction. And what it says on here is no shame or blame, just love. And I think that's what all of us collectively together really need to be and have at the forefront and have kind of in our hearts. And I know you all have that in your hearts as we are really looking to figure out how to get more people into recovery and understand that there is hope. There is that recovery that people can experience. This morning, I also had the opportunity to see somebody who is now really working and her opiate use disorder is stable, and now she's really working on her alcohol use disorder. And so seeing the transformation, seeing the just light in her eyes was a great start to my day. And I also want to just mention that this is not just about CSAT. It's not just about SAMHSA, as you've heard. This is really about the entire federal government. HHS, the Health and Human Services Department, about a year ago developed an overdose prevention strategy that includes 4 pillars rather, and one of which is recovery supports. As Dr. Clark mentioned and Michael Langer mentioned, this is all the way up to the president and the administration have really called for addressing the opioid epidemic and the mental health crisis in the country as top priority number 1 and 2 in their State of the Union, in his State of the Union address last year. And the National Drug Control Strategy lays out over 80 action items for the federal government to take across prevention, harm reduction, treatment, and recovery supports to really being able to get a handle on this. And the Assistant Secretary at SAMHSA has laid out 5 pillars, including one of preventing overdose, but across those 5 pillars are some key overarching principles, recovery being one of them. So recovery is baked in and infused into everything that we do at SAMHSA. And I'll talk a little bit more about that. The second principle that the Assistant Secretary has set out as being an overarching principle is one of equity. Dr. Clark mentioned that we really need to be looking at everywhere, every community. And we know that there are some communities that have been disproportionately impacted by the overdose epidemic. So making sure that we are reaching out and connecting with people, whether it be on street corners, in bars, in churches, in hair salons, etc. It's so exciting to hear about the work that Washington State is doing in that arena. The third principle kind of that overarches all of SAMHSA is that of workforce. And Michael Langer mentioned that. We absolutely acknowledge that having a robust, diverse, and well-trained workforce is critical. Otherwise, the provision of treatment and recovery services is extremely difficult. No matter how many facilities there are, no matter how many houses there are, no matter how much great technology we have to connect each other. And we know that there are currently significant workforce shortages. 37% of the US population, in fact, lives in a mental health worker shortage area. And SAMHSA and the Health Services Resource Administration recently co-sponsored a workforce projections report that highlighted the behavioral health needs of America. And in that report, they identified that there will be a shortage of 31,000 full-time specialists across psychiatry, psychology, and mental health and addiction counselors by the year 2025. In that report, there is also a significant mention of peer support specialists. And SAMHSA supports a peer recovery center of excellence, which is a technical assistance and training entity that helps recovery community organizations, other treatment providers, hospital settings, other types of settings, you name it, really help to establish and train peer support specialists so that they can use their experience, so that they can use the experience that you all have and grow that part of the workforce. Because we know at CSAT and at SAMHSA that peer recovery support specialists really play an incredible integral role in engaging with individuals to help them establish and see the benefit, the possibility of recovery, and be able to maintain that. We've seen that particularly during the COVID pandemic, but even prior to that. And with those lessons learned from the COVID pandemic, really being able to establish and grow that piece of the workforce is an incredibly is a significant priority for us. So the other thing that Dr. Both Gitlow as well as Clark and Michael Langer mentioned is the recovery definition. And Dr. Clark read the definition that SAMHSA developed in conjunction with a lot of stakeholders, a lot of people in recovery, a whole breadth of individuals now over a decade ago. And that definition is one that has resonated with me as a provider, a public health official, as well as now at SAMHSA for the past year. In fact, we recently held a 2-day recovery summit that some of you may have participated in, you may have heard about this, but it brought people together, people who are in recovery, researchers, providers, advocates, federal partners, and for the first time ever, really people from the harm reduction community. And during that summit, attendees overwhelmingly reaffirmed that definition. And so it is, I think, a testament to just how solid that definition is, how much it resonates with people, that process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. And it forms the basis for all the work that we are doing also moving forward. I just wanted to end by saying that as Dr. Clark and Michael Langer, I think all of you also may have heard about, is that this is an administration that really prioritizes moving recovery forward. One of the ways that that has been demonstrated is that about a year ago this month, the first ever Office of Recovery was established at SAMHSA. And while there is much that SAMHSA is doing that is related to recovery, that office is going to continue to push the envelope even further. And that includes making sure that we are holding to that principle of infusing recovery into all of SAMHSA's policies, programs, services. In fact, we have in the last year in all of our notice of funding opportunities really tried to infuse recovery and the recovery definition into what we expect grantees to really be able to speak to, as well as support both some required but allowable activities so that grant funds can be used to support recovery housing, peer recovery specialists, recovery community organizations, and making sure that all of those support services are available to grant recipients. Dr. Clark mentioned the president's proposed budget of a 10% recovery set aside in the substance use block grant that has also then been identified both in the House and Senate language. So we are looking at that. We're obviously going to be following that very closely. And the administration also has supported an increase in the state opioid response program that provides significant flexibility and funds to states like Washington and across the country for lots of activities and services in the continuum of prevention, harm reduction, treatment, and recovery supports. In fact, just about an hour ago, there's a big White House Recovery Summit event where ONDCP Director Dr. Gupta, as well as the Assistant Secretary, have been meeting and talking with panels of people in recovery to understand and make the announcement of those now FY22 state awards for that SOAR program. There is also an accompanying tribal opioid response program, because we really want to make sure that dollars are getting to those communities that are in great need of them. And so I'm going to just close with that. I want to say thank you so much. The other thing that I was thrilled about personally, having an opportunity to visit with the Mobilize Recovery bus tour that made its way from the West Coast all the way over to DC last Friday as part of SAMHSA's Recovery Month event. And it was amazing to see all of the names that people had written from across the country, writing their names and recovery dates, and just an incredible amount of energy, enthusiasm, and hope and love. And I think that's what carrying forward, that is certainly what I'm going to be doing. And I hope that all of us collectively, we really will be able to see those numbers of overdoses can decline and the number of people in recovery be able to increase. So thank you so much for having me. And with that, I'll turn it back over to Dr. Gitlow.
Thank you, Dr. Olson. We certainly appreciate everything you've been doing for us there in Washington. Thank you again. As you know, we started a few minutes late. We're running just a couple minutes late. We have one more speaker for you, Yvette Torres, the consultant and former associate director for consumer affairs at CSAT.
I'm going to try to be nice because the panel is about the state of recovery in America. And what we have to look at, in part, and I applaud everything that has been said and everything that folks are doing, but in reality, I came to Seattle, and the first thing I do, I go to Mass every morning. Today I didn't because I was here. But at the church, they had a policeman because apparently the homeless come in, and in order not to disturb the Mass, they have to have a policeman there. I took a drive to get a massage out to about 30 minutes north of Seattle yesterday, and I saw encampments of homeless everywhere. The city, I went to Pikes Peak or Pikes Market, tons of homeless. Then we also have to look at the rate of domestic violence in America, which a lot of it is caused by alcoholism and drug use. And we have to look at traffic fatalities in this country And we have to look at issues that affect the longevity of life in individuals, such as, as has been mentioned here, the overdose deaths, compounded now with the COVID-19 pandemic and everything else that we're facing. So I'm not going to be satisfied in my lifetime until all of those rates are reduced and people have what we used to call the no wrong door. Do you remember that? The no wrong door to recovery, which meant that emergency rooms and everybody else had to be connected. And in order for that, in my view, in order for that to be decreased, I'm in communications, so I look at where are the avenues where people that need to get into recovery are getting a message that there is hope out there and that they can call and get help. So I don't know, inform me. Where do you see that now? Huh? Where do you see it? Internet. Sure, the homeless have their little phones and are trying to get access to that. So, yes, but part of that is that there has to be a forum where messages are getting out to communities about people like yourself that are in recovery, and recovery people need to be telling their story. And they need to be telling their story publicly. And with all due respect to SAMHSA, I looked before I came here to the panel, and I went to see how many Recovery Month events were listed. And I don't know if there are people here that used to visit the Recovery Month website before, when there was a Recovery Month website. Now it's just a little folder. The mention is there, but it's not as robust as it used to be. And there were like 9 events versus the thousands that we used to list. So the other factor is that when an organization like the Oxford House, with more than 1,800 or 1,500 or 1,800 folks are here, you would think that if you have a recovery office, that they would come to press the flesh, because I think that part of the success in the past was that people got to know each and every one of you, and listen to you. And I know that they're listening to people and so on. So why am I saying this? I'm saying it because you have a responsibility. You have a responsibility not only to run the houses, to run them well, but you also have a responsibility to look within your communities and see how you can spread the message of your recovery to other people who need to come into recovery. And there were many, many mechanisms before that one could do that. There were public service announcements. There were cable television shows that took the best from SAMHSA and put it over the public channels in cable. And perhaps they can't afford that now, but there has to be something. You need to find those mechanisms because you have access to your local cable channels. And any one of you can become a producer. Quite frankly, you should check it out. It's really a lot of fun. You walk into your local cable channel, they will train you how to use a camera, they will train you how to develop a program. In order for the public channels to include the issue of recovery, of people in recovery. It's as simple as a host, someone who wants to be a host, or someone who wants to interview people about their recovery. You can highlight people like, let's say, the director that was here, and have him talk about to the local community and have him talk about what they're doing. And in that way, you could have a number where people can call if they need housing to go to an Oxford house. So the messaging is my point. The messaging about recovery needs to get out. Because as far as I'm concerned, there's an awful lot of people that need help. And in order for them, it's hard enough for someone to admit that they have a problem and that they need help. But it's even harder for them to be able to seek that help and to find assistance. And many of the ways that we were able to get people in recovery is by having them listen to your stories and having them understand that I also can be in recovery. If they could do it and they went through X, Y, and Z, then I too can do it. So in closing, I didn't mean to offend anyone, but the reality is that we have a long way to go. We have a tremendous long way to go. And I think that I want to motivate each and every one of you in your communities not to be shy about your success, not to be shy about what you have accomplished. Because the bottom line is that you can be that vehicle to make recovery in America long-lasting for people that really need help. And in closing, I bet that a lot of those homeless that are here and throughout America are vets. They've given their life to their country. So one of the things I was thinking about yesterday when I saw those encampments, and I said, a lot of these people are vets. And I said, maybe Oxford House, you have homes for women and children, you have homes for men, you have homes for women, you have homes for men and children, which is so admirable. And maybe one of the concepts, and you can bring this to the World Forum, is why not have a homes for vets? Because they have a particular issue with PTSD. And you could focus on that and help. So think about that. And with that, I thank you.
All right, thank you very much, everyone. We'll still be up here for a little bit in case you guys want to come up and ask some questions, but otherwise we'll see you in a little bit.